Welcome everyone to this ISHLT Cardiology Professional Community special webinar. Today we have the honor to have great speakers on the webinar titled Saving the Gift, Critical Challenges After Heart Transplant. I am grateful to present our first speaker, Dr. MaryJane Farr, who joins us as the Section Chief of Heart Failure at the University of Pennsylvania, with her talk, PGD in the Hot Seat, Early Recognition and High-Stakes Intervention. Thank you again, Dr. Farr. Please go ahead.
I'm unmuting. Hi. Thanks for the invitation. Okay, saving the gift. Updates on PGD after heart transplant. Let's see. Okay, here are my disclosures. I'm on the Academic Steering Committee of Transmedics, and I can't give a talk on PGD in 12 minutes. Okay, so here are our agenda that we're going to try to get through. We're going to talk about incidence and risk factors. We're going to talk about the PGD consortium, evolving management strategies, the ways the DBD and DCD might be different. And with that, the impacts of different perfusion and preservation platforms. I'm going to mention in just 10 seconds the new ISHLT classification scheme, and then how to stay in control if or when your center's severe PGD case load increases. Okay, so here's a case. Here is a young woman who's been on a VAD for a long time on guideline-directed medical therapy, and including SGLT2 inhibitors. She is somewhat obese. She's got a driveline infection. She gets a donor who's 47. Good size match. The donor is being hyperoxygenated for lung recruitment. Predicted heart mass is within a range that we think is acceptable for DBD. There's no significant bleeding. Early graft function is okay, but comes off cardiopulmonary bypass, and then there's pretty profound biventricular dysfunction, and she is urgently placed on VA ECMO. If you look in the fine print, there's some fever, there's hypotension, there could be a little bit of underfilling, but nevertheless, on a highish dose of inopressors, this patient is failing, and the mixed venous is 23. There's no choice but to put the patient on VA ECMO. So what is it? In short, as we know, it's LV, BIV, or RV dysfunction after heart transplant. In the setting of low cardiac output despite adequate filling pressures. There's no identifiable etiology. We know that's not true. There's lots of etiologies that come together. It's not just vasoplegia, and I don't want to just say just because vasoplegia has a profound mortality attached to it. We think we've optimized our donor-recipient pair as much as we can in the setting of organ scarcity. We think our surgeon and anesthesiology team has been pretty good, and severe means VA ECMO. Here's the evolution of PGD from my perspective, and that is a 20-year perspective. And, you know, this is an American perspective. I did put the radial risk score here in Italy that was sort of happening a little bit earlier than we got together in the United States to really think about all of this, but the advent of VADs, the advent of new allocation, the advent of new guideline-directed medical therapy, the wait times got longer, the non-pulsatility may play a role, and now we're in this other phase where there's a new consensus conference that was just finished, and we're in the age of DCD and different kind of platforms, and it gets really complicated to try to figure out, you know, what's true and what's not true and how to fix the problem. Okay, so there were registry definitions at the outset. ISHLT and SRTR still have registry definitions that are hard endpoints of death or retransplant, but we were missing a definition. So this consensus conference, you know, over a decade was really, really important to establish a universal definition to try to get some estimates, create opportunities for research. And we think the incidence is somewhere between 10 and 20%. But this definition, we really never quite made it to ISHLT for lots of different reasons. And now it is with OPTN or UNOS or the other way around since September 2023. In the interim, let me just show you something that I did a number of years ago with Lauren Truby, who was a young resident at the time, and we were really very interested in the rates of severe PGD in the setting of LVAD. We saw that there was a marked difference with these patients. They were more likely to have PGD, they were less likely to survive. And looking agnostically at all these different variables, we came up with a set of variables that really spoke to end organ dysfunction of the kidneys, RV failure, subtle or otherwise, need for amiodarone, and long time on non-pulsatile VAD. And this was in the setting of DBD, standard cold storage, old allocation, and we saw a lot of heart block and problems like that. This resonates with many people. And then came the International Consortium on PGD that was really founded by 3 fellows, Truby, Moietti, and Farutin. And this is an unfunded registry. It doesn't include everybody, and this is the problem with registries, that the folks who don't have this problem aren't participating. The folks that have such a bad problem may not want to participate. And so there's a lot of non-coverage when it comes to sampling, but it provided some information, and certainly global information, about PGD. Here's a more updated look at what we're seeing from the consortium, and that is that the rates in US, Canada, and Europe are about 8 to 10%. And there are different trends. Things are on the rise in Canada, but we do know that the survival are different across different areas of the world, with US having the best survival. And we all have different problems. We all have organ scarcity problems, but we have different problems, donor age and so forth, that go along with different countries. I just wanted to mention that Truby and I took another look at this, LVAD, in this larger, more contemporary data set, well, 2010, but through to 2022 in the consortium. And we found that LVADs were still a problem. 12.7% had severe PGD, but we looked at some of the usual things that we had looked at before. But what we also noticed was that the survival was better and PGD with LVAD rather than medical management. And you can imagine that that's because of congenital heart disease and other types of ways in which patients were either not eligible for LVAD or they had different problems. But to underscore it again, this included now DCD, controlled cold storage, new allocation schemes. So you get information, but the waters are muddied even a bit more. There are many different scorings and systems that are out there. Radial is old, European or Italian, didn't include LVAD. ABCE came out of Cedars-Sinai. It really spoke to the risks of our guideline-directed medical therapies and our antiarrhythmics before transplant. And, this will maybe hold some of those things, although the patient will get worse. Predictive from the UK told us something about need for ECMO before, no surprise. And the PGD AI calculator out of the consortium is working with how to best predict. The question is if you took any of these predictive models, can you prevent PGD? Is there anything you can really do? Well, if you know the donor age, bypass time, but it's really hard to turn down a donor for a recipient, especially who is dying, knowing fully well that you may enter a PGD event. There's a little mechanistic studies that happened over the years. There are lots of them, but I'll show you 2. This is really about the recipient as the toxic milieu. This was a 3-center study of Columbia, Cedars-Sinai, and Salpêtrière in Paris. And we looked at serum samples 24 hours before transplant in all comers, and we found that there was decreased kallikrein levels, which maybe spoke to the consumption of this enzyme, indicating that perhaps there was more vasoplegia or occult or over-infection in these patients. And then Truby and the Duke group did a sort of a similar model and came up with CLEC4, which is a protein that is along the innate pathway in the dendritic pathway, and to say the same thing, that maybe there is a occult or manifest infection that is portending cytokine release. You can imagine the stories that we all tell each other. And so what do we do about that? Well, we do know that 2 empiric therapies of the same mechanistic insight is CytoSorb, which is extracorporeal blood purification device in the OR, and there's a study in Vienna ongoing, and also clinical use of plasmapheresis to pherese off perhaps some of these toxic cytokines. Vasoplegia, I'll just mention it here. We all have different definitions, but we know that we see vasoplegia, and there's a lot of overlap between vasoplegia and PGD. One important thing, and I don't think we spend enough time on, is in the operating room, because if you're a medical doctor, you're of course not there. But when is the vasoplegia happening? If it's happening during the adduction phase, is that unroofing infection? Is that bleeding? And so is the recipient on high-dose pressors and volume overloaded even before the heart's arrived into the room, and then the heart is put into an environment that's highly toxic? Or is the vasoplegia et cetera, happening on cardiopulmonary bypass or just off. And I think those things really, of course, do matter. Back to the consortium, we did have some information on vasoplegia, and no surprise, the mortality was greater than 20%. Okay, on to a couple of things. So therapeutic plasma exchange, this was work that Dr. Kabashigawa has been working on for a long time, and this was finally published. This is really a retrospective observational, and so there's differences in which patients got plasmapheresis and which ones didn't. The ones that did survived better than those who didn't. So what does plasmapheresis remove? Well, it removes bad things, cytokines, too much amio, ARNI, and so forth, but it also removes some good things like T3 and T4 and mycophenolate and other good antibodies, not just bad antibodies, and vancomycin. So you've got to really be careful, if you want to use this therapy, and I like to use this therapy for PGD, but you also have to be mindful what also has been taken away. Do you need to actually replete T3 and T4? That's another tricky subject. So let's go to the donor. I have just 1 or 2 minutes. PGD and DCD, the early rates were extremely high. This is Australia and the UK. Here in the United States, here is Duke. Their rate of PGD in patients with DCD very early on was 34%, but they were noticing that these patients actually were surviving. Now we're at DBD versus DCD. In my mind, PGD with DBD was heart block and those types of problems. DCD, you see a lot more of VTAC and cardiac enzymes. That speaks more to procurement and donor injury rather than some toxic milieu of the recipient. Here's a little analysis I did of SRTR, and we're really seeing that the rates of DCD, PGD are high. I don't know what that X is on the screen. There doesn't seem to be a difference in procurement platforms. There's debate about that. All we can say is there's lots of procurement platforms, everything from OCS to NRP to controlled cold storage, which made a big impact on PGD, decreasing the rates. And now we've got continuous cold perfusion, and now re-up, which is non-continuous cold perfusion. So here's just a quick sneak peek at the consensus conference, and I will, all this to say that early graft dysfunction is going to be the nomenclature, and there's going to be some distinguishing between what happened on bypass, what happened off bypass. I'll leave it at that. It will be published in April. And then lastly, the patient who had PGD, it wasn't heart block, and it was a big disaster. We pheresed her a few times, and her rhythm returned, her pulsatility returned, and she ultimately did fine. So how to handle a rash of PGD events? Oh, you can do all the things, but start talking to other centers and certainly participate in any kind of registries that you can to try to get at some of this information and contemporary risks for PGD. Thank you for your time.
Thank you, Dr. Farr, for an excellent talk. For all the audience, we're going to have a session of discussion and answers at the end of all the talks. So our next speaker, we welcome and thank Dr. Katerina Vasilev, who joins us from the Bulgarian Academy of Sciences with the talk Decoding Rejection, What the Pathology Really Tells Us. Dr. Vasilev.
Thank you very much for the kind introduction, and I'm absolutely sorry, but I think I'm again unable. Here it goes. Oh my goodness, I'm so sorry. We had some issues from the technical batch. Can you see my screen now? Is it showing?
Yes, we can.
Oh, wonderful. Thank you so much. So it is a pleasure delivering my talk. I have been tasked with giving an update on acute cellular and antibody-mediated rejection. And unfortunately, we are still updating our guidelines. So there is really nothing new. But of course, I'm going to highlight what we are seeing basically and how we are diagnosing our biopsies. So from a pathologist perspective, that are not the only two diagnoses which we are excluding in every biopsy or in every sample that we receive. Of course, we are looking for infections, we are looking for recurrent diseases, and of course also neoplastic diseases in the late post-transplant period. But we are going to focus here on the acute cellular rejection and the antibody-mediated rejection. But first of all, let's start. Why we often do not come to a conclusive diagnosis. It may be due to the morphological features of the specimen. So in many cases, basically up to 15-20% of the cases, the sample or the histopathology report may state that the sample is inadequate. And it's not to say that the pathologist thinks that there is some clinical incompetence, but that the material may have been sampled from an area which is relatively cardiomyocyte poor. For instance, the right ventricle in some cases is composed of large amount of cardiomyocyte or fat tissue. In other cases, you see that these areas have been sampled already, and the biotome just entered again. So you have here a previous biopsy site with coagulation tissue. And in the post or the late post-transplant period, you may encounter severe cases of TVP with transmural fibrous remodeling and scarring, where it's almost impossible to reach myocardium. So you can imagine if you push really hard and you are in an area which is bordering with a larger, or when you reached the free wall in some cases, then this may have adverse implications. So in these cases, probably you won't receive an appropriate answer, histopathology report. Therefore, we recommend to submit more than 3 biopsies to increase diagnostic sensitivity, or at least in 2 or 3 to receive some endomyocardial tissue. And here actually you can see there's a beautiful endomyocardial tissues. Our last consensus document is from 2004. So now it's really time to update it. And as you can see, this is actually referring to the even older classification of 1990. Therefore, the new classification has an R on it, which means revised in the grading system. Whereas we have now 4 levels or 4 grades from 0, 1, which are the low grade ones, which are often not associated with any kind of symptoms. And then the high grade rejection, here's a 2R, which is characterized by severe lymphocytic infiltrates, which are associated with cardiomyocyte damage, which is missing in the low grade cases. So the distinguishing factor is actually the myocyte injury between low and high grade. The quantity and infiltration of T lymphocytes refers to the diffusity of the inflammatory cell infiltrates, and also then differs to the grade. We have an exclusion. Just a second. I'm so sorry. It's here. Most endomyocardial biopsies are surveillance biopsies, most of which show no lymphocytic infiltrates and are therefore termed grade OR, which translate into no evidence of rejection. But in presence of lymphocytic infiltrates, you may encounter some very localized structures, which are actually quality phenomena, which do not influence the grading system at all. Historically, there has been really low pathologist agreement on differentiating between focal and diffuse lymphocytic infiltrates, meaning as a grade 1A and 1B, which have now been combined into 1R. And we seldomly observe higher grade acute cellular rejections in surveillance endomyocardial biopsies, most of which fall into the category of 2R. These are characterized by more than 2 foci of lymphocytic infiltrates associated with cardiomyocyte damage. I'm so sorry, I'm experiencing some technical issues. The presence of endothelial cell swelling, perivascular distribution, or presence of mononuclear inflammatory cell infiltrates in more than 10% of the lumens of small vessels, and edema raises then the possibility of antibody-mediated rejection. So there has been an AHA statement from last year, which actually go a bit more deeper. These are studies which have been collected at least from 15 years ago. I've been working in different centers, and we have tried to establish all these antibodies which are listed here, but none of these alone are diagnostic for AMR. In my opinion. Also, the anti-HLL antibodies stain basically everything, in my opinion, or in my experience. The only really discriminatory factor is the presence of neutrophils and capillaries in low-grade AMR cases and less expressed AMR cases, and the beginning of interstitial edema. So, antibody-mediated rejection is again classed or graded in 4 categories. One is 1I1 plus, so meaning that from the histology part, you need to have intravascular macrophages and or prominent endothelial cells and perivascular infiltrates. This defines the histology grading. Either you have no infiltrates and none of these features present, which is H0, or you have these features, then it would be an H+, independent of the expression of C4D. In combination with C4D, you have expression of C4D in more than 50% of capillaries, which would amount to PMR1 plus, I plus, meaning immunohistochemistry is positive, but you have no histology, no histological features. Then you have the H plus and the capillaries. Sorry, this is mixed up. And then you have the PMR2 if both are concordant. So histology negative, immunology positive is immunohistochemistry positive, histology positive, immunohistochemistry negative is histology positive. From here, we must distinguish the expression pattern or the distribution pattern, because C4D needs to be expressed in at least 50% of the capillary with an intensity of the staining of at least 2 and 3 plus. So if you define 2 and 3, this would be a 1 because it's granular, it's not circumferential, and this is a 2, and very strong is 3. So this wouldn't count, this would count, but still you have over 50% of the capillaries, so it's a PMR1. You may also use immunofluorescence, but different centers have different protocols, and it's best to stick to the protocol of your center because it's established. In addition, you have a severe challenge in diagnosing AMR because C4D is not only a product of activation of the complement cascade by AMR, but may also be observed in hypoxia. This triggers the absolute same reaction, leads to the development of the split product C4D, which then binds to the endothelial cells and forms a covalent bond via a free electron in the outer space. So this bond, even if C4D afterwards is resorbed, remains. It leaves a footprint on the endothelial cell. This footprint is detectable up to and the kidney transplant professionals even claim 3 months after the initial event. So even though there is no anymore, or the AMR episode has been resolved, you may detect C4D. And interestingly, not only C4D, but also C3D, whereas C3D is less stable, and is less expressed. So even if you have a fully blown histology and immunohistochemistry positive case as this one, C3D may be expressed in a, let's say, less severe pattern. So it may be expressed in up to 20% of the capillaries. So we do not have reliable criteria to diagnose it. But in combination, if both of them are positive, then it's a good indication that you have an AMR case, at least immunohistochemistry. And I must say, the kidney people precede us or have more experience, at least for 20 years, so they're much more advanced in their diagnostic defending. So what I wanted to stress on is that peri-transplant and reperfusion injury lead to expression of C4D. Here in this case, not very much expressed, but you can see that the dying cardiomyocytes are actually also expressing C4D, but in the cytoplasm. So here, I'm not sure if you can still recognize this. For most of you, pathology is a bit, you have seen it during medical school, but this is this very hyper-eosinophilic cytoplasm and the loss of the nuclei. So this is a very good indicator that these cardiomyocytes are hypoxic. But in differentiating peri-transplant and perfusion injury from AMR, you are missing the lymphocytic infiltrate. It's basically the cardiomyocytes are dying without any cellular features. And I'm sorry again, I have to go back. So what the HA scientific statement from last year proposes is to use a plethora of immunohistochemical stains. And as mentioned, I have tried them all. I must say, even in homograft hearts, meaning the explanted hearts, the pediatric hearts, and the autopsy hearts, most of them have or expressed to a certain degree C3 and C1q, even in the pediatric population. The best coefficient of diagnostic accuracy I have found in C3D and C4D in combination. HLL, as mentioned, HLL is basically expressed in every single biopsy. It's very difficult to establish the stain, and the same applies to fibrin. So for CD31, I would recommend when assessing the mononuclear infiltrates or in the lumen of capillaries, or a double staining would be even more recommendable, in particular if it's crushed or in pediatric biopsies, because these are very compact. It's very, very difficult to assess. So in this case, it would make sense to apply more than one stain. But as mentioned, it is very difficult to maintain a very good quality of the stain if that is not a highly specialized pathology lab, basically specialized in transplant or in cardiovascular. From differentiating between high-grade acute cellular rejection and PMR3. Basically, it shows the same clinical symptoms, and it simply doesn't matter because the graft is failing. As you can see here, all these pink hypereosinophilic structures are cardiomyocytes, which are, most of them are dead. They lack nucleus. The interstitium is severely dilated by edema. All these dots here are mixed inflammatory cell infiltrates, including neutrophil polymorphs. So even if this resolves, there has been extreme tissue damage already established, because these neutrophil polymorphs actually secrete also some enzymes. So there is complete tissue destruction and all this loss of cardiomyocytes. It's very difficult to compensate. So the ventricle will probably not be able to return to normal pump function. As MaryJane already mentioned, an interesting aspect is the HLA expression in pre-sensitized patients. And as she mentioned as well, I had also the feeling that those patients on MCS, which have been bridged to transplant with MCS, showed a higher percentage of cases of AMR. But when I looked into the statistic, I think I followed them for 1 year, consecutive biopsies. I think there were 230 patients. It was not, at least histologically, not statistically significant. So we couldn't reach statistical significance except for cases which had combined C4D and C3D expression, which is interesting. So that only shows that pathology is just one puzzle piece in all the diagnostic criteria, and that basically biopsy timing is important to establish the diagnosis, because as I mentioned, you need to time it properly. The cascade had to be initiated, the split product had already to be found to bind, or the other bond need to be established, and the clinical symptoms should not have been resolved already, because then you have the best chances that the pathology diagnosis actually correlate with the clinical symptoms. Otherwise, it's extremely, extremely difficult. And
please wrap up. Thank you.
Okay. And an additional feature is, as I mentioned, this is a rat model. So we just did a rat model, and so it depends also where you biopsy. So you can see the best chance to get a positive biopsy is actually in the free wall, which no cardiologist would really like to biopsy. And you have fewer infiltrates in the interventricular septum, and the right ventricular side of the interventricular septum, which is so you would need to submit more tissue to have actually a positive sample. So in this regard, as more samples we receive, as more accurate would be the diagnosis in these cases. So as William Osler put it, as is our pathology, so is our practice. But I must say, pathology is just a puzzle piece, and we are actually happy to be part now of a team, as no specialty can diagnose these conditions sufficiently alone. In particular, in the high-grade rejection cases, which are often associated either with gastrointestinal episodes of diarrhea or in suicidal attempts. These are the only three cases I really encountered on autopsy in PMR3 and ACR3 cases. One collapsed in a parking lot. Another one was illiterate and failed to follow the medication scheme. And the third withdrew the medication voluntarily after 2 heart and 1 kidney transplant. So I'm happy to answer questions. And if you have become interested in pathology, and I hope we can put out our consensus document soon. There are 2 courses, one which Andriana is featuring with Professor Kubashigaba, and one will be held in Sofia. So we would love to see you in both. Thank you very much, and I'm happy to take questions.
Thank you, Dr. Vasilev, for a great comprehensive talk, very interesting. I encourage the members of the audience, if you want to put any questions in the chat, and we will go ahead with the discussion after our next speaker, who is Dr. Palak Shah from Innova Shah Heart and Vascular in Virginia, United States, with his talk, Rejection Realities, Turning Suspicion into Swift Action. Dr. Shah, please.
Great. Thank you. Thank you for the invitation. And I don't have as many nice pictures as Katerina, but I'll try to build on some of the concepts that she talked about in her review of the pathology. Here are my disclosures. So I only have about 10 to 12 minutes or so for this talk, so I won't be able to cover all of the different molecular diagnostics and biomarkers that are available in heart transplantation, but I direct you to this review article that was published a few years back that really has a nice comprehensive review of the topic, and also I think does a really good job explaining HLA antibody sensitization, donor-specific antibodies as well. So I will talk specifically about donor-derived cell-free DNA and specifically donor fraction. Whenever you think about any sort of biomarker that we're using, whether that's a troponin, an NT-proBNP, and cell-free DNA, there's 3 basic stages that really are important for biomarker development. One is analytic validation, really understanding that what you are trying to measure, you are able to measure reproducibly across labs. Clinical validation, showing that this really does work and correlate with the outcome of interest. And then ultimately clinical utility trials that really demonstrate clinical benefit and efficacy and improved clinical outcomes with the biomarker of interest. And the graft study, which I had the privilege of working with Dr. Hannah Valentine as well as Sean Agbor-Eno through the intramural program at NHLBI, was really the clinical validation of donor-derived cell-free DNA in both heart and lung transplantation. And this unique intramural, extramural collaboration really led to foundational evidence supporting the use of this as a non-invasive biomarker of allograft injury and rejection. I'm not going to go over the entire study, but donor-derived cell-free DNA performed quite well with respect to its ability to detect both cellular as well as antibody-mediated rejection based on histopathology with excellent sensitivity and specificity. And really the concept that potentially if you used donor-derived cell-free DNA as a screening tool, because of its high negative predictive value, you could potentially eliminate surveillance endomyocardial biopsies after transplantation. But there are some other unique features of this paper. One of the things that we talk about a lot in our field is that there's a little bit of heterogeneity in terms of how histopathology is interpreted. And what we notice is that, and one of the critiques of donor-derived cell-free DNA is that the positive predictive value is low. But one of the things that we noticed was that many of these kind of quote unquote false positive cell-free DNAs with a negative endomyocardial biopsy actually preceded the histopathologic diagnosis of rejection, most commonly antibody-mediated rejection, by a period of almost 3 to 4 months. And in many situations, the cell-free DNA was elevated, and even though the histopathology was negative, the patient had a drop in ejection fraction, suggesting that there may be an alternative mechanism of allograft injury or potentially rejection that was missed by biopsy. So what's new? We spent the good part of almost a decade now talking about donor fraction, but more recently there's been an interest in quantification of cell-free DNA or the absolute quantity of cell-free DNA. If you look at this illustration, I think the important thing to note is that the majority of cell-free DNA that we have in our circulation is actually from the recipient or the patient themselves, greater than 99% of it. And so any fluctuation in that recipient cell-free DNA, which is that blue color, will lead to a change in the donor fraction. And what's been increasingly recognized is that when patients exercise, let's say they have an infection, their renal function fluctuates and things like that, that recipient cell-free DNA goes up and down, and that can affect your donor fraction, leading to either false positives or false negatives. The other thing that's been noted is that as you look at donor fraction as a function of time post-transplant, which is that blue graph at the top, the donor fraction seems to go up naturally on its own as a function of time post-transplant. On the other hand, the absolute quantity of cell-free DNA, which is the numerator in those equations, is relatively stable, and that's the donor quantity score in red. So this work that Paul Kim and Joseph Stellick led showed that both donor fraction, which is what we're used to using, as well as the absolute quantity of cell-free DNA were both elevated in the setting of rejection. And that perhaps if you used both of these tests in conjunction, you could eliminate some of the false positives and false negative test results that you get when you look at donor fraction alone. And overall, there was a reclassification of about 16% of the samples based on using combined testing. Well, we talked a lot about histopathology, but let's talk a little bit about clinical outcomes. So we recently completed this study called DEFINE-HT, which was presented last year at the ISHLT, which really looked at moving a little bit beyond just a biopsy-proven rejection and focusing on the association between donor-derived cell-free DNA and clinical outcomes, future rejection episodes, graft dysfunction, retransplant, and death. This was a large multi-center study. Patients were prospectively enrolled and followed. And you can see that there was about 1,100 cell-free DNA measures and about 900 biopsies and about 800 echoes. So quite a bit of data collected on these patients through that 1 year post-transplant time period. This, I think, was relatively humbling to me. I think it's amazing that even in a contemporary heart transplant cohort, the event rate is actually still quite high for our patients. 36% of patients had an event, predominantly treated rejection, but also graft dysfunction and death that occurred most typically within the first 30 days post-transplant due to PGD. We saw an association between donor-derived cell-free DNA percent, as well as the absolute quantity and clinical outcomes. And even with adjusted analyses, patients who had above threshold results had about a 4 to 5-fold increased risk of future rejection, graft dysfunction, or death. I thought this was very interesting. In the study, we had 40 episodes of rejection. 25 of those episodes were actually treated. 15 episodes were not treated by the clinicians managing these patients. You could see of the untreated episodes, the majority of those were antibody-mediated rejection. And so back to Katerina's point earlier, some of these patients may have persistent immunologic or histologic findings suggesting antibody-mediated rejection, even though they've been already treated for their rejection episode. Interestingly, the cell-free DNA levels seem to correlate with our clinical decision-making, which is always good. The higher cell-free DNA levels were noted with patients who were actually treated for their rejection as opposed to episodes that were untreated. I'll talk quickly about antibody-mediated rejection, and then we'll talk a little bit about treatment. This is some work that Jason Goldberg led, and it really tried to get at the temporal association between cell-free DNA, DSA development, and then eventually antibody-mediated rejection. And I think the important thing to note here is that when patients have donor-specific antibodies and LV dysfunction, even in the absence of histopathologic rejection, their cell-free DNA levels are high, and their clinical outcomes actually afterwards on follow-up are worse, suggesting that this kind of DSA, LV dysfunction, cell-free DNA positive phenotype, even in the absence of histopathology, is essentially an AMR equivalent. This work from the SHORE registry looked at antibody-mediated rejection specifically, and you can see an increased risk of histopathologic AMR based on escalating values of cell-free DNA. But if you look at the box on the bottom right, I think it's important to realize that yes, the cell-free DNA level is high, or the donor fraction is high when patients have antibody-mediated rejection. But even after patients are treated for AMR, their cell-free DNA levels often do not return to normal and have the kind of persistent elevation in donor-derived cell-free DNA. We recently published this position statement on antibody-mediated rejection, and I won't go over the entire treatment algorithm. But the thing that I want to alert you to is really this the bottom of the graphic, which gets at how to follow these patients afterwards. And given the fact that the biopsies are often persistently positive, considering using donor-derived cell-free DNA as a way to track response to therapy and to determine whether or not patients have any sort of recurrent AMR. I'm going to talk briefly about MMDX. There are 2 studies that were published in the past 2 years looking at MMDX and donor-derived cell-free DNA. And what we see is that the cell-free DNA correlates much more strongly with the MMDX diagnosis of rejection compared to traditional histopathology. And then the other thing that is very interesting is that when MMDX diagnoses cellular rejection, it seems to have higher donor-derived cell-free DNA and more pronounced graft injury than what we typically see with histopathologic cellular rejection. So in a contemporary era, you may be at a program that does endomyocardial biopsies as your surveillance tool, or you may be doing donor-derived cell-free DNA testing as part of your surveillance. Importantly, this graphic and this algorithm is not targeting patients who are symptomatic, who have graft dysfunction, who have abnormal hemodynamics. It's basically the patient population that's really undergoing surveillance. So let's say you do an endomyocardial biopsy first. If the patient is truly asymptomatic, even if there is histopathologic rejection, I think many of us are starting to question whether or not that patient should be treated purely based on histopathology alone. On the other hand, if the if the endomyocardial biopsy is negative, given some of the data that strongly associates cell-free DNA with clinical outcomes, many centers are actually checking a cell-free DNA to see whether or not there is evidence of allograft injury that warrants a further workup. If you are one of the more centers that has adopted cell-free DNA, if your donor-derived cell-free DNA is negative, then you're kind of done. There's no indication for endomyocardial biopsy. And if it's positive, then of course you'll do an endomyocardial biopsy and then either treat the patient or consider, if the biopsy is negative, doing kind of a further workup where you look at donor-specific antibodies, MMDX, cardiac MRI, coronary angiography to try to understand the mechanism of graft injury. So just to wrap up, donor-derived cell-free DNA is not just associated with histopathologic rejection, but also clinical outcomes. DSA plus LV dysfunction is essentially an AMR equivalent. You can use donor-derived cell-free DNA to track response to treatment for AMR and identify recurrent AMR. And I think as a community, I think we spend a lot of time talking about rejection. I think we spent quite a bit of time today talking about it, but I think we also need to think a little bit about some of the complications of our immunosuppressant medications and other factors that limit our patient survival after transplant. Thank you.
Thank you so much for our amazing speakers for these fantastic talks. I would like to start with a question for all of our speakers, and I'm going to hear the perspectives of the pathologists and our amazing clinicians as well. But let's start thinking about AMR too. I would say the bane of our existence, and particularly asymptomatic AMR2. So from the pathologist perspective, we saw the deficiencies of many of these immunohistopathological markers, the long half-life of C4D, and also we're not even capturing complement regulators that might be blocking the activity of these complement fragments. And also it's very subjective kind of assessing just endothelial, swelling, because it seems it's a very subjective measure to be looking at these measures as kind of indirect evaluation of injury. So from the pathologist perspective, what other markers would we want to see on histopathology to understand when there is actually injury to the myocardium? And from the clinician standpoint, when we see AMR2, again, completely asymptomatic, we have data from numerous studies showing us AMR is pretty in asymptomatic patients, is very well tolerated, even up to 3 years on follow-up. One, should we be treating it? Two, what other biomarkers would we use? Cell-free DNA, MMDX, antibodies, and what levels of those do you use in your center to trigger any treatment? So very complicated question, but we'll start with Dr. Vasiliev.
So thank you very much for this question, which I think is extremely, actually it tackles one of the problems which we have. And again, let's mention that we are at least 20 years behind of the kidney people compared to the kidney people who have developed a much better system. But as you mentioned, endothelial swelling has been one feature which has been used in an era where even immunohistochemistry has not been established or was not established as a diagnostic marker. So, but it shows something, it activates something. So it shows that the myocardium was activated, or at least the vessels. And it's a plethora of all kinds of morphological features, including the biopsies before and after the event. So I think what most studies are focusing now on are biopsies from a certain time point. I think what we are missing is the development. There appears to be something like really chronic AMR from the very beginning. And probably that is it. This was MaryJane also recognized, because I've seen it as well. If you have, and this, I statistically, it's impossible to show. If you have a case of a patient who has severe peri-transplant injury, and this peri-transplant injury pertains for more than 3 months after the biopsy, and the C4D is consistently positive, probably because the myocardium is undergoing some reparative changes, then the prognosis or the outcome appears to be worse, at least as long as I followed the biopsy, because then you have the activation of the interstitial macrophages. It's not only the AMR. You have, first of all, the fibrin clots, which block the terminal vascular network, meaning you have chronic or hypoxia, relative hypoxia to the terminal myocardium. So not the first three layers, which are actually fed by the blood flow from the ventricle, by diffusion via the endocardium, but, you know, the terminal net. So you have a subendocardial scar probably from the very beginning. Then you have the ongoing activation of the interstitial macrophages, which probably cannot be silenced because you have constantly these antibodies in your bloodstream, your all kinds of enzymes which are working in the interstitium, and all this is probably afterwards constituting a worse outcome, which one factor is unable to capture, in my opinion. It probably starts already from the cold ischemic time. But to put all of this into perspective, you need really supercomputers, and you need to follow these patients strictly using surveillance biopsies, using all kinds of tests, all data, to capture all data which have been shown, like also HLL class 1, class 2, compared with C4D, C3D. And I must say, unfortunately, there is not anymore so much money in the system to do that. Not to talk about that someone need to sit down and to consistently capture all the data, to introduce it into the computer, to feed it properly into the computer. You cannot use students. So there are a lot of features, but I think we will get there if we continue using all the different methods and you know, collaborating, because I think the most important part to keep the protocols which we have and not to lose one of the tests or to complement it with the other, because now we start to gain knowledge. And this knowledge, yes, I do not want, yes, I'm so sorry for the long answer.
We'll give also the word to Dr. MaryJane Farr to see in her rich experience of over 20 years, how does she handle asymptomatic AMR too?
Okay, so I think much more about long-term survivorship. So if the patient feels well and the graft is functioning well, and you have recent assessments of coronary disease, preferably by PET CFR, I would focus in on things like de novo donor-specific antibodies and other ways in which the graft may be affected, and try to just be sort of see the biopsy. And I've got one patient who is chronically expressing HLA-2. We more detailed assessment of the biopsy, and they're there, but the patient is not rejecting, but could at any point. So I think the clinical, and it's a long-term thing. Folks who are sensitized or have donor-specific antibodies and have biopsies that are a little bit complex and never super clean, you know, you could bring them to an early death by over-treating. And so, yeah, I'll stop there. You get the point.
Absolutely. And Dr. Shah as well, because you're the king of all the biomarkers, cell-free DNA, your work on microRNAs, also obviously digital pathology. So how do you integrate when you encounter on biopsy asymptomatic AMR2? What is your go-to next line of testing?
Yeah, sure. So, I mean, I think a couple points to highlight, right? I think AMR number one seems to occur early after transplant, or at least the histopathologic AMR occurs early after transplant. And I think we have to recognize that if there is some graft preservation injury, maybe that leads to some expression of some of these HLA molecules, and then all of a sudden we get AMR by histopathology, and otherwise the graft looks good and the hemodynamics are good, right? And so I think distinguishing when a patient is truly has graft dysfunction, abnormal hemodynamics, I think is critical. I think if, to Jane's point, you know, if the patient has donor-specific de novo DSA plus AMR2, I will treat. I don't think I stop at that point. I think that is enough for me to kind of, I guess, quote unquote, pull the trigger on treatment. On the other hand, if they don't have donor-specific antibodies and they just have AMR2 and they're doing fine otherwise, that's when I'll look to do a cell-free DNA to see if there's any allograft injury and or also an MMDX to try to see if there's a molecular pattern of AMR that we're not seeing based just to kind of help with the decision making, again, because of the risks associated with the therapy.
Fantastic. And kind of hearing from all of our speakers with all of these events, we're worried about the long-term graft survival. And chronic AMR being the biggest Achilles heel of our transplant patients. So how should we be evolving our surveillance protocols long-term with these biomarkers? Because we're very comfortable using cell-free DNA biopsies, the first 1 or 2 years post-transplant, and then kind of a big gap. So in your experience, how often are you checking cell-free DNA beyond the 2 years? And kind of what thresholds or HOAs or, triggers for biopsies or cardiac MRIs or PET imaging? And what triggers you to be very aggressive and reach for any treatment? And again, I'm going to start with our clinician, so Dr. Shah.
Sure, yeah. Annually post-transplant, like I think you're getting toward more the intermediate long-term phase, we'll do annualized cell-free DNA monitoring along with graft dysfunction as well as donor-specific antibodies as an assessment tool for graft health, along with PET-CT, which Jane was talking about. I don't think we have great biomarkers right now to look for to assess long-term graft health. We don't really have that, right? And I think there's been a lot of interest in this concept of the iBox and using an iBox as a surrogate measure to understand long-term graft outcomes. And I think, Katerina, to your point, the kidney folks are much farther ahead in this. They're looking at drug development around using iBox as a validated surrogate of future outcomes. So I think we need to develop novel biomarkers to prognosticate patients.
Fantastic. And Dr. Farr as well.
Yeah, I think, first of all, it hasn't been studied, right? We don't really know how to use cell-free DNA in folks who are 10 years out, et cetera. Once we do get an abnormal result, we can't help ourselves but to biopsy the patient. Sometimes it's nice, of course, to do something a little bit more in depth, like MMDX and all the things that Palak's already mentioned. We're all very good at chasing our own tails. But while we're doing that, a patient can become very sort of unroofed by the whole thing. More testing, back on a drug that they were weaned off of. Maybe that's a good idea. Maybe it's not. And then there are some folks who are doing well, and once they mount a positive cell-free DNA, it may just always be positive, and so it's going to be then relative differences. But again, we don't really have any data to tell us what incremental change is important. The copies is obviously promising. I'll leave it at that.
Perfect. It's really the decisions are often triggered by a single time point measurements when we should be looking probably at trajectories and kind of multi-biomarker assessment.
And then I guess last thing always that we have to really distinguish what we're doing for cause and what we're doing for surveillance. We even if it doesn't change exactly what we do, we have to at least document it that way so we know what we're doing. And that's where data got really complicated, in some of the observational registries.
Absolutely. And there is a question in the chat from Anju Bardwaj. If MMDX is positive, especially if no obvious dysfunction on echo, histology is negative, what is your standard follow-up strategy? Do you trend DSA, cell-free DNA? When do you repeat biopsy with MMDX? And we'll again go down the line as well. Dr. Farr.
Jane, I think you're on mute.
I like MMDX. I think there's a curiosity to it, where you look and you can get a sense of where your patient is on the spectrum, and it's, it all depends on why you biopsied the patient in the first place and why you sent the MMDX. And again, it gets to this issue of surveillance versus cause. We don't have this right. We don't know why we do the tests that we do, except that we feel better when we have negative, the negative predictive value is so important, but we really don't know what to do with this information. I would say, just from a clinical point of view, we tweak a little bit. We may augment immunosuppression, but in a more rational way, maybe a little bit up on the mTOR and a little bit down on something else. Again, but that's true clinical medicine. It's not a guideline answer necessarily, of course, right?
Absolutely. And Dr. Shah, what about you?
I mean, I see there's another comment also about MMDX, and I guess how are we using this, right? Are we using this as a screening surveillance tool, MMDX specifically, or are we using it as a diagnostic tool? And so I, in clinical practice, really use it more as a diagnostic tool in someone who I have concerns about graft function, donor-specific antibodies, biopsy, allograft injury based on cell-free DNA, but I don't necessarily do it routinely as part of a surveillance strategy. And so I think we have to be careful about what the approach is for using these types of tests.
Excellent. And I see Dr. Farr kind of following up that MMDX is used more as a tiebreaker. And I think in our center also, we don't use it routinely, only for cause biopsies as well. So that's kind of helpful in deciding what to do with the patient. Well, we are right on the hour. I think this was a fantastic discussion. If people have any additional questions, they can always go to ISHLT Connect and we'll connect them with our speakers. Thank you so much to our esteemed panel. This was very informative. Thank you for everybody joining us.